Hey guys, good evening. I am super excited to be going live tonight with the amazing Dr. Smotrich from La Jolla IVF in San Diego, California. I'm also really excited. Hello, those who are joining. I'm also really excited to be live for the first time since announcing the initiative Fertility Clinics versus COVID last night, which is set to help 8 people restart their journey for free. So over the last 4 months, I have been working every day on this initiative to help those who have been affected by COVID in their fertility journeys. And we are partnering with 8 fantastic top-class clinics and a sperm bank around the world to offer 7 free cycles of IVF and donor sperm to one person or couple. So there'll be 8 people who will benefit from this around the world. The link is in the bio. Please head there, check it out, read about all of the different partners and how they can help, and enter or apply. And also, as well as this, during this 8-week campaign, I will be going live every week with each of these amazing partners to cover all sorts of fertility topics, answer your questions, hear from the specialists, and not only that, also go live with all of our wonderful campaign ambassadors who are just such pillars in the community, and we'll be hearing about their personal individual stories, which are all very, very different, and their struggles, so that people realise that they are not alone and can ask them questions too. So I'm going to be joined by Dr. Smotrich any second, and tonight, to kick off this 8-week series of chats, we're going to be talking about how you can work with your specialist to get the best results. So if it's not working for you, should you consider a different specialist or a different clinic? What are the questions you should be asking, and how can you work with them to try and maximise success? So obviously communication is key. Let's see if he's here. Hi to those who are joining. Not here yet. Whilst I'm waiting, does anybody have any questions about the initiative or the partners that are involved, or how to redeem, what's going to happen to the people who are successful? It is random selection. No story is more deserving than another. And this will be happening, you can apply through until the 10th of March, and then we will be randomly selecting. And we just really hope that it's going to help people restart their journey and bring back hope, and also just do some good and just take things a step further this year. Hi to those who are joining. Let's see if he's here. We had a quick chat last night to talk through it, so hopefully he'll be here in a second. And also, to cover the conversation that I'm having with him tonight, has anyone got any questions in advance about his practice, what his specialities are, anything that you might be concerned about with your own specialist, or things that you want to ask? Then do ask, because he wants to help and answer. Now, I'll just quickly tell you about the 8 partners whilst we're waiting. They are worldwide, so anyone around the world can apply for this incredible opportunity. And the fertility clinics are based on the West Coast and the East Coast of America, and also in the UK, and also in Europe. And then the sperm bank, Cryos, is international. So really an amazing opportunity to spread what we can around the world. Just seeing if he's here. Not here yet. We'll give it a little bit more. And if you do have any questions about the initiative, then please just send me a message now. You can just DM me if you don't want to ask publicly. And I think that as well as these lives with all of the medical experts, it's going to be amazing to hear from the ambassadors. You may have seen the videos that they've been posting in the lead up to this. All care about mental health, all understand the struggle, all have faced their own different challenges. So it's really the most amazing community, and a community that I wish that I had had when I was going through this. So let's see if he's here now. Having a look. Not yet. Is anyone on at the moment who is from California? Be interesting to know where people are in the world at the moment. And the other thing to note is that if you go to the website, and you can go to the link in bio to find out more about the terms for each clinic for the redemption of this amazing opportunity for those who are successful. We've obviously taken into consideration timings because of COVID and travel restrictions, so you can read it all there and what their rounds include, etc. So check it out. The link is in the bio. Let's see if he's here now. Not yet. If not, I might have to hop off and then hop back on. Does anyone have any questions whilst I'm waiting? Otherwise, I might leave and then come back on. Please feel free to ask. And then I will be just updating everyone with the different conversations that I'm going to be having over the 8 weeks. Hello to everyone who's joining. And they, as I mentioned, they really range. So we'll be covering all sorts of topics. And also, if you have any topics that you want me to speak to with them, to have your questions answered, then please do. There'll be webinars too. The COVID vaccine is a big one. Someone said it's so amazing, this opportunity. Yes, I hope so. And hello from San Diego. Yep. Just really want to spread some hope and do what we can in this really bleak time, because it's obviously been devastating seeing everyone have journeys stop because of finances, COVID, wait times, etc. And I think that you probably agree that feeling is everywhere in the world. So we're in lockdown at the moment in the UK, and I just think some optimism and some hope is a good thing. Let's see if he's here now. I'm wondering if I can add him. Thank you for bearing with me. Let's see. I've requested, so let's see. Have your questions ready? So Dr. Smotrich has worked with some really complicated cases, and he's also been a pioneer in many different things. We were having a chat last night about this live, and I was amazed by the things that he has done and seen. So, you know, whether you've got a complicated situation or not, it's interesting to hear his perspective on things. He did tell me last night that he often sees people who want to maybe continue with their eggs and they're well into their 40s. So he's going to talk a bit about that, about being an advocate and working with your specialist about, you know, obviously having the best chance you can have, but also making sure that you're listened to so that you're not necessarily, you know, swayed into a situation that may not be what you were anticipating. Just waiting for him to join still. Okay. Oh, they're here. Okay, there we go. Thank you for being patient, everyone. Let's do this. Okay. I hope the connection's good. Let's see. Just waiting. Hello, good evening.
Hi, how are you? Can you hear me okay?
I can. You're in your scrubs.
Pardon me?
You're in your scrubs.
Yes, well, we had a procedure this morning.
So I've just given a brief introduction to you and talked about our brief chat last night and the amazing cases that you've seen, and obviously patients being their own advocates for talking about what they might want or need, and obviously looking at success at the same time. So before we go into all of that, please could you just introduce yourself and tell us a bit about the practice and your background, and also just explain to the people watching, because I've just briefly reintroduced Fertility Clinics versus COVID, how you're offering this amazing opportunity of a free round of IVF to help those who have been affected by COVID.
So first of all, thank you so much for having me, and good evening to you in England, and good afternoon to those of us on the other side of the pond, as they like to say. So I'm Dr. David Smotrich, the founder, medical director of La Jolla IVF. I've been in our community now for 26 years. I've been on my own for 23 years. Opened this facility back in 2000, and been very fortunate to take care of patients from all over the world. I have done over 7,000 surrogate cycles in my career, done over 6,000 egg donor type cycles in my career, well over 9,000 IVF cycles in my career,
Wow.
and done over 4,000 genetic screening of embryo cycles in my career. I really like to partner with my patients to be able to have them as actively involved as possible with every single decision that is made. Obviously, these are very emotionally charged cycles for all patients, and I'm very willing to push the envelope, if you will, and I have very upfront, honest, and straight discussions about what the expectations are and what we anticipate with regards to success. I pushed the envelope, and we've done quite a bit of pioneering work. I was the very first practice ever to do pre-implantation genetic screening of embryos, where we look at all 23 pairs of chromosomes. So that happened in our facility here. We had 2 separate patients have the first singleton, and then the next case was a twin pregnancy using that technology. So that happened in our laboratory here. My laboratory director also is the lab director at Stanford University, Dr. Barry Baer, so he's intimately involved with every case that we do here. I do all my own ultrasounds and all my own procedures, so we have a modest-sized practice, but I'm very hands-on, and I think that a lot of patients appreciate that.
Definitely.
In 1997, took care of a couple. It was a male-male couple, which was the first ever in the world using an egg donor and a surrogate, and we got all the laws changed in the state of California, our state, to allow for this male-male couple to not only do this type of procedure, but they were fortunate to have a child with us, and were able to change the laws to be able to have both dads on the birth certificate. One of the very first practices ever to work with female-female couples. Female-female couples have a lot more hardware to work with, if you will, than male-male couples. So, that didn't get as much attention, but we were one of the first cases where we got eggs from one woman, created embryos, and then put embryos into her partner. So both women were actively involved in the same case.
Fantastic.
You're asking about women who are over 40 or patients who have had failed cycles before. Yeah. So a large part of my practice is indeed working with patients that have had outcomes or poor outcomes elsewhere. And I have very frank discussions, and sometimes, again, these are very emotionally charged situations for our patients, but I feel that it's very important to understand exactly what they've been through, review what the protocols were, talk about the pros and cons of going forward versus not. So, for example, I had a 51-year-old woman in my practice who was still ovulating and still having periods every month. Now, her chances on paper of having a genetically normal embryo and having a healthy child is in the neighborhood of less than 1 in 100 million.
Wow.
And I had that conversation with her, and she wanted to try and make eggs. And I said, okay, I'm happy to do this, but you understand that if your eggs don't fertilize, they stop growing in the laboratory, or are not genetically normal, that I'm hoping that you will still have the wherewithal to go to egg donor. And in that situation, we got 2 eggs from her, 1 embryo. Unfortunately, embryo stopped growing on the 3rd or the 4th day, which tells us that it was most likely genetically not normal, and that was what she needed, if you will, to close that chapter, to be able to open the next chapter that actually helped her have a healthy child with us. There are lots of cases of patients that have had cases done elsewhere, and I'm not saying that we have any magic in our laboratory or we do anything unusual here, but I don't like the concept of just slamming the door on patients. Very large percentage of our patients are very well educated in general, very well read on what's involved in the IVF process. I have patients who come in with lists of questions about protocols, about types of medications, about culture media that we use in the laboratory, about all the different things that we're looking for and looking after. And I think that this is very, very important to keep the active conversation going. I've had a lot of experience. I've been very fortunate, but I can't imagine, or I can't comment that I have seen absolutely everything and done absolutely everything. So, and I've always relied on my teachers to be able to call them. Most of them are on the East Coast right now, and some of them have already been retired because I've been doing this quite a while. But, I like to pick the brain of other colleagues to make sure that, the things that we're talking about are still fresh and make sense.
Yeah.
The coronavirus and the pandemic has been something that has impacted the entire world. It has impacted every single person. And it's something that we all have to kind of work with together. So I took my mask off, but we're all wearing masks every day in our office in order to get into our building. The temperature is taken to get into our actual physical building. Then in our office, everybody has their temperature taken. There's a questionnaire that is tested, and every single patient is seen individually so that the waiting room is quiet and there's nobody, waiting, potentially having any infections at all. Every single patient, egg giver, sperm giver, somebody who's having a procedure within their uterus, is having indeed COVID testing. I had my second vaccine yesterday, so I'm still kind of numb, if you will, in the arm. But and because of the amount of cases that I do with patients, and I have a mother who is elderly, who's in a memory home. I'm frequently tested just so I have the permission to go and visit her. So I think I've taken probably 8 to 10 COVID tests. I've been very fortunate to be negative with every one. I understood that you had COVID yourself.
Yeah.
So it's a very, very difficult disease for many, many people. I think that a lot of people, especially in our area, underestimated how devastating it is to tell couples that they have to wait for things. So we didn't close. We abide and continue to abide by the laws that the United States, and we just had a change in leadership, but the state of California has with regards to, there was a time when we had to close our operating room, so we fortunately, were able to delay patients or just continue to take care of patients that were on medications, but we've never turned patients away during this entire procedure, and during this entire pandemic, excuse me. I don't anticipate that we will stop any of our patient care. I don't believe in withholding care. I don't like that conceptually. I'm not wired that way, and so I have like-minded people on our staff, and we are being as safe as possible during the pandemic. But you gave us a wonderful opportunity to give back, and many people right now are really hurting, and we just. I've been very fortunate. I grew up in a Jewish home, and my grandparents instilled something called Tikkun Olam, which in Hebrew means to heal the world. And this is basically to try and do things that are helpful for others. And I think I have a reputation of being one of the only IVF docs that actually say a prayer over the uterus and abdomen of a patient after I've done an embryo transfer. I say Genesis verse 1, chapter 28, both in Hebrew and English, which is, and God said, be fruitful and multiply. So it's the very first commandment of God to humans, and I think it's very apropos that it talks about having people be able to procreate and be able to extend their families. And I think that this is really an area that we've been fortunate to be able to help people with.
Definitely. And am I right in saying that you do a lot of this yourself? So when your patients are waiting for their pregnancy test or their beta test, you speak to them and just sort of manage the whole process.
Look,
No, you're so busy.
I try and practice the same way I would, hoping that my daughters or my wife or my sisters would be taken care of. So I'm very hands-on. After you do an embryo transfer, frankly, it's in God's hands. And so you're waiting frequently 12 to 14 days to find out if your said procedure worked or not. I'm a big believer in bed rest, so I put my patients on bed rest for 3 days, and there's not a lot a person thinks about during this time other than, oh my God, I hope this worked, and oh my God, what happens if it didn't? So I try and call with encouragement, and prior to COVID, I was very fortunate to travel all over the world to lecture about, IVF, egg donation, surrogacy, genetic screening of embryos. In fact, my wife felt that it was very important. We've been married for 30 years now, and we're blessed with 3 adult children, and actually our first grandchild turned 6 months
Oh,
old yesterday, so she's been visiting with us. But my wife felt that it was very important to bring our children everywhere we lecture and everywhere we traveled, so that they could get what she calls a university of life kind of experience, which really I think was very, very thoughtful. And so my youngest daughter had been to every continent in the world except for Antarctica, and I haven't been to Antarctica yet either. But that we've lectured. So I've lectured in Southern Africa, in South Africa, Johannesburg, and Cape Town. I've lectured in North Africa, in Marrakesh. I've done some charity work for patients, believe it or not, in Uganda. I've lectured all over the United States, all over Europe, all over Asia. Been to Brazil several times to lecture. So
amazing.
we've been very, very fortunate to travel all over. And what's clear is that this is something that in the heterosexual couple, little girls think about from when they're young. And I saw this, my eldest child is a girl. Danielle is now 28 years old, and she's the one that made me a father and a grandfather. And, we had a son 3 years after she was born. My son Ariel, and my wife was breastfeeding, and my daughter would see my wife breastfeed, and she'd run to get a dolly, and she put her dolly to her breast. And so this is a child of age 3 who is seeing what her mommy is doing and understanding from God knows where that this is something that she is looking forward to. And now I'm watching my daughter breastfeed her, well, not watching, but she's breastfeeding her
Yeah,
daughter on their trip. So
yeah.
with us. So, I mean, this is something that is quite innate and something that I'm very passionate about. So all those trips, when I had patients waiting for pregnancy tests, I would call them. I would call them with pregnancy results and, time zones and all those kinds of things taken in consideration. And that way people really understand that it's my job, if you will, what I do, but it's much more than that, and it's much more than that for our entire staff. We're frequently here 7 days a week. We don't get snow like other areas, but rain or shine, if you will. And but if you love what you do, it's not really working. You just get to go and do what you love to do. So that's how I'm wired. And we have some very difficult types of situations. I mean, I've taken care of patients who have lost their children and now are trying to have another child after a child has passed away. So there, in my opinion, very few things that are worse than a death of a child, but we have quite a few patients like that. We've had patients whose sons have passed away and they were able to surgically remove sperm within the first 72 hours of their sons passing away, and then getting permission with the lawyers to be able to use the dead sperm or the dead son's sperm to have another child. So we've done that a number of times. Again, we're not here to judge who wants to be a parent. But we're here to try and accommodate everybody. And as I had mentioned earlier, I think it's very important for us to be able to partner with our patients to be able to have that frank discussion.
Definitely.
So I have a patient in my practice who's new to my practice who is 42 years old. And she had an IVF cycle 3 years ago, and she had 3 eggs. And she remembered that her ovarian reserve was low, but she didn't know what the exact number was. And I had a very frank discussion with her and her husband about what are her chances. And, she wants to try to get her own eggs, and I've created a protocol for her, and hopefully next month she will do well. But she understands that she had a previous procedure that did not do well. She had a low ovarian reserve, and even though her chances are low, she wants to try. Now, I'm not going to have her try 18 or 20 times. We'll try once and see how she does. And if she does well, fantastic. Or if she almost gets to the outcome we want, perhaps we'll do another cycle. But one of the things that were quite interesting for me, especially as a young physician, is I got involved in third-party reproduction and genetics early in my practice. And for a long period of time, surrogacy was either not available in your native Britain and many different countries throughout Europe. And as the world became smaller with the advent of these kinds of technology items, the internet, computers, and all the like, the world became smaller and people started to reach out for help. And so, I would have patients specifically remember when 9/11 happened and the United States had to close all the airspace. And I had a patient who was on an airplane coming from Europe who had failed 15 embryo transfers because she had a uterine abnormality and lived in a country where surrogacy was illegal or not allowed. So I had to get permission from our government to allow for her to actually fly here so that we could take care of her, and she wound up having twins with us on her first attempt using a surrogate.
Wow.
So, there are a lot of these wonderful stories that are fresh in my mind as we start to come across various different milestones in the world and things like that. But, if you're a physician, and I don't even blame the physician, but if you're a physician sitting in Germany or Italy or France where surrogacy is illegal or forbidden, you can't really be sitting there talking about surrogacy. And, I trained, I did my subspecialty training at George Washington and the NIH before there were computers, before there were cell phones, frankly, before we even knew how to grow embryos to the 5th day and do genetics and all that. So all of these things are constantly changing, and we're incorporating the technology in the cycles that we do, in the laboratory that we do, and then things that we're able to aid patients with. So I think that this is a very unique perspective that makes it easier for me to be able to communicate with our patients and be a plethora of different options when it takes time to actually go forward and do a cycle for them.
Mm-hmm. Thank you for that. Fascinating. We've had a few questions come in. Please, could I ask if people are here? And then I just want to briefly just summarize, the topics about what people can do to be their own advocate in terms of the questions they can ask and when they might want to think about different routes or switching clinics or looking at other options. So someone has asked, our problem is egg quality. Whilst in our second IVF, our 5 embryos reached day 3, we got just 1 blastocyst, and our doctor believes the issue is still the egg quality. What are your thoughts?
So egg quality is something that is very challenging, and again, I don't know the age of this patient, and I don't know what her ovarian reserve testing is. But what you described, yes, most likely it is an egg quality issue where the other subsequent embryos did not grow and develop and probably stopped growing because of genetics. As a woman gets older, or let's go back even further, the main difference with regards to fertility between men and women is men can make fully functional sperm until they die. Sperm counts do indeed go down after age 50, significantly down after age 70. But in our community, we've had patients where the men are in their 70s pushing 80, and if they're not able to get pregnant at home, we get sperm from them, create embryos in the lab, make sure they're genetically normal, and we've been able to have healthy babies for these gentlemen with either their partners or eggs from an egg donor into a surrogate. Women, on the other hand, are born with every single egg they're ever going to make. When a girl is born as a baby, she has the ability to make about 2 million eggs. When she first started having her periods at age 13 or 14, she has the ability to make about 200,000 eggs. Every month, she has a certain allotment of follicles. Follicles are fluid-filled structures that have the potential for eggs. And if those follicles are not releasing an egg and fertilized, or if an egg is released but not fertilized, all those follicles for that month and that egg as well is absorbed by the body. Now, as a woman gets older, over 38 and especially over 40, not only does she have fewer eggs, but the eggs that she makes has as many as about a 73 to 80% genetic abnormality rate, so that egg may fertilize and may create an embryo, but it'll have a high risk of being genetically not normal. So these are conversations that I frequently have with my patients. And in that particular patient, if that one embryo is indeed genetically normal, then we would probably start by working with that one embryo. If that embryo is not genetically normal, then we would use a very creative low-dose type of medication protocol to try and get some eggs, but eggs that have not been negatively impacted by the medications that we use, to hopefully have an embryo or two that is genetically normal. That would be a conversation that I would have with that particular patient and make sure that they understand that, yes, we've seen this. Yes, I've had success with that, but she may be at a point where she's at the end of her rope with regards to being able to make eggs. The menopause in women means that they no longer make eggs. Now, I have patients in my practice for genetic reasons that are in their early 20s and no longer make eggs. I have patients that are 46 years old that were able to make 25 eggs and have a handful that were genetically normal, and we've had children from those patients, and virtually anything in between. And the other thing that's important is that couples need to understand that we're their best advocates. We try very hard to do the things that they want to do within the guidelines that they set, but there are times where a woman is not going to make eggs anymore. And for most women, this happens mid to late 40s. And it is very devastating when it happens, but no matter what protocol you come up with, a woman's going to stop making eggs.
And actually, leading on to the next question that we've got, this reader has had 3 recurrent miscarriages. I'm so sorry. After ICSI, never fallen pregnant naturally, unexplained infertility. Her husband has 1% morphology, and they've had every test under the sun. It's shown to have raised natural killer cells, and it's been put on hold because of COVID. And as we can have steroids and intralipids, we can't, I presume, have steroids and intralipids that we need. Would you say PGTA would be a good thing to consider?
PGTA, definitely, and consider gestational surrogacy. And, natural killer cells is one of these things that is very hard to quantify. But there are a subset of patients that the natural killer cells prevent an embryo, no matter what kind of embryo, quality of embryo, from implanting. And so frequently, if that truly is the diagnosis, certainly people will want to try again with their own uterus. We reevaluate the uterus. We may add steroids during the stimulation. We may add various different blood thinners to increase blood flow to the uterine environment, but no question genetics would be something to test before placing an embryo into the uterus, because in my opinion, genetics are very, very important. When you have an embryo that you know is genetically normal, not only does it have a higher rate of implantation, but it has a lower rate of miscarriage, and obviously this is ultimately what we're trying to do, is have a healthy baby.
Mm-hmm. Yeah, that's great advice. Thank you. Also, a question about, just praises for you. My
Thank
issue
you.
is egg quality, age 33, low AMH, IVF, not good response, LH surge cancelled, IVF turned IUI, resulted in pregnancy, miscarried at 8 weeks. What do you suggest?
Okay, so a very challenging case, unfortunately, a young woman with a low ovarian reserve. And the possibility of that miscarriage is one of 3 things. 1, genetics, because if they losing at 8 weeks, sometimes an embryo will start to implant and then doesn't continue. Hormone levels, which if she was in an appropriate place, I can't imagine they weren't checking her hormones carefully. Obviously, I would also wonder if there was a uterine issue, making sure that the uterus is normal. But in that case, again, I would probably encourage her to re-stimulate, to understand that she may only get a single egg, and there are different protocols that we use for a patient that we anticipate only 1 or 2 eggs from, and follow them very, very carefully, and then watch that embryo grow and develop, and encourage her to have genetic testing. Most women who are under 35, the genetic number of or abnormality rate is about, or at 33, should be in the neighborhood of between 45 and 50%. So this is something that we didn't touch on, but I think is important. So I have a large patient population of egg donors and cases that we do with egg donors that we do genetics on. Even with a young, healthy woman in the egg donor age, which is generally under 30, not every follicle has an egg. Not every egg is healthy enough to fertilize. Not every fertilized embryo continues to grow and develop to the blastocyst stage, and not every blastocyst staged embryo is genetically normal. So while we are primarily doing genetics for aneuploidy and older patients to see if they have any abnormalities, many of the patients that now move to egg donor are doing genetics either for sex selection, which is completely legal in our state of California, or trying to make sure that they're not selecting one of the embryos that is genetically abnormal, which is at a rate of about 40 to 50%, even from eggs that under the microscope subjectively look beautiful and are coming from an egg donor. So that's how I would pursue that patient, and I would also have a frank discussion with them with the understanding that even though she's a young woman at 33 and she's had already one canceled cycle, that this is going to be very challenging for her, and she may need to consider using an egg donor or getting one egg from her and adding eggs from an egg donor and mixing embryos prior to, sometimes I've put one embryo from an IP and one embryo from an egg donor to try and enhance the chances of the embryo from the egg intended parent implanted. Now, it's rare for us to put more than one embryo in, but sometimes this is what we need to do for intended parents and intended moms to hope that they're still involved, but still add and allow for the embryo from an egg donor to be added to their care.
So what happens in that situation if you've done that? If the patient becomes pregnant, how do they know which has been the successful embryo?
So I've done it many times. I've done it hundreds of times. Sometimes both embryos implant and they have twins. Most times it's one embryo that implants, and if they're very curious, they can always do genetic screening on their new child to see if they're genetically related to the child or not. But that is something that is up to the intended couple, and it takes a special intended parent to understand that these are the different risks and benefits. But again, when patients are willing to be creative, and when their doctors and teams are willing to be creative, most people wind up with success, which is what's really wonderful and why we all do this in the first place.
Definitely. Another question, kind of similar to where we were. Do you know any research for genetic mutation of, is it LH receptors?
No, not off the top of my head at the moment. And, that sounds like a unique and interesting situation, and, need somebody to really review everything and to have intimate involvement with their laboratory, perhaps even to speak to the different pharmaceutical companies that make the medications that we use to allow for release of eggs and things like that. We do a lot of single gene disorder testing, so couples where each member of the couple are, let's say, carriers for cystic fibrosis or carriers for sickle cell anemia or BRCA, which is also very, very common in certain populations. And we've been very fortunate to have healthy babies where we're able to prevent a disease from happening in the next generation, which is another very exciting part of the expansion of the genetics prior to an embryo transfer. But in terms of the LH receptors, there's 2 or 3 different types of medications that we use to try and mimic the LH surge to allow for the egg to be released. And there's a couple of medications that we use to try and prevent a woman from prematurely releasing an egg. And sometimes you have to tinker, if you will, with regards to protocols to maximize chances for success.
Great, thank you. The questions are coming in quite fast now. I don't know how much time you have, but someone is 41, has an AMH of 15. Would you suggest IUI or go straight to IVF?
No, in my opinion, women who are 40 or above, an insemination really is not very helpful. So let's take a woman who's under 35, has normal uterus, normal fallopian tubes, and a partner with normal sperm. In that perfectly quote-unquote normal parameters patient, insemination may have in the neighborhood of about 12 to 15% chance of success per cycle. Now, granted, it is less invasive, it is less expensive, but the reality is a 41-year-old has about an 82% chance of having embryos that are genetically not normal. And so with such a high level of that, and most 41-year-old women have reduced ovarian reserve. So moving more rapidly to advanced therapies not only can be therapeutically helpful, but diagnostically helpful as well. And you might be able to be blessed to have several embryos that are genetically normal, whereas if you spend 6 to 8 months doing inseminations, you may not get pregnant, you may get pregnant and have a miscarriage, and now when you're ready, if you will, to move forward with IVF, you may have already wasted a large time of your ovarian reserve capacity. Now, obviously, I'm not going to push a patient. I will have an open and honest discussion with them, again, going back to partnering with them and individualizing every single patient's care is very, very important, in my opinion. But in that particular scenario, I would not encourage her just to do insemination because, I think that it's very important for people to realize how challenging it is for a woman over 40 to have a successful pregnancy using her own genetic material.
Thank you for that. I hope that's been helpful to the person watching. And lastly, someone said that unfortunately in Boston, most clinics don't believe in PGTA. They only offer that to you when you've had 2 miscarriages or more. And any suggestions on supplements to improve egg quality?
Okay, so we do a lot of supplements. Going back to your first comment about clinics that don't believe in offering genetic screening, women sometimes underestimate how powerful they truly are. And I think that it's very important for a patient who on paper should be doing genetic screening, which is frankly any woman over 35 or any woman who's had a miscarriage, really should be pushing hard. And if it's not working with who they're working with, work with somebody else. Don't waste your time, because the last thing you want to do is, have undergone 2 or 3 IVF cases, not have been able to have genetics done, have a false sense that you have, 6 blastocysts that are frozen, and it turns out that of those 6, perhaps only 1 is genetically normal. So it's very hard to give guidance to that. Sorry, I missed the second question.
It was about melatonin and egg quality.
Oh, okay. So, there's a number of different supplements that we encourage. Melatonin, not necessarily one of them. It's clear that egg quality and egg number and ovarian reserve now is significantly decreased compared to what it was 20 years ago. It is clear that sperm counts are down probably 30% compared to what it was 30 years ago. Most of this is related to the toxins that we are all exposed to, even if you're trying to be careful. So there are toxins in the air, toxins in the food that we eat, toxins in the and even hormones if you eat meat or chicken or things like that, toxins in the fish that many people eat. So these are things that are concerning. the air that we breathe is significantly different than it was 25 or 30 years ago, and obviously this is dependent on where you live in the world. Prior to COVID, as many as 50% of the patients that I took care of were indeed from mainland China. So in the industrial parts of different nations, there are huge air pollution issues. There's huge water pollution issues as well. And in fact, there was a study that showed that even in a woman who's trying to eat as healthy and be as organic as possible, that as many as 140 different chemicals could be detected in her newborn baby, even when she's trying to be careful. And a lot of these are breakdown products of various different chemicals in the air. So supplements that I like for women, DHEA. We encourage antioxidants, CoQ10, baby aspirin. In Europe, it's 100 milligrams. In the United States, it's 81 milligrams. These are things that are all very helpful. There are things that women can do with regards to diet and exercise. There are things that women can do with regards to acupuncture that have all been supportive. Unfortunately, these supplements, these ad care things and self-help things that women do, meditation, yoga, things like that, are not going to be the answer if they really have a horrible ovarian reserve or they have a very bad genetic makeup of their embryos. And that's also very difficult because I've been fortunate to take care of many women that are very professional, that have been very successful in all aspects of their life, and they say, this is what I want to do, this is what I have to do it, and this is how I get my success. And unfortunately, with regards to fertility, it doesn't work that way. I mean, persistence generally is rewarded, but just because you're very focused in all this, and if you're 45 with a poor ovarian reserve, you're going to have a very, very low potential for a positive outcome. And so, again, that's why it's very important to partner with couples to have a very frank discussion on, what the numbers are. Going back to the 41-year-old, even if she does in vitro, if she has a single embryo that is genetically normal, in assuming it's a good quality embryo and her uterus is normal, then she may have in the neighborhood of about a 60 to 70% chance of pregnancy. Whereas just walking in at 41, her numbers may be closer to 5%. So again, it's very important to have, these active discussions, to discuss it not just one time, but from various different aspects so that, hey, you may not have understood or it didn't register the first time. I use a lot of graphs, I use a lot of pictures because I think that it's very important for people to understand. And again, we've been humbled. I've been humbled all the time. So, I learn a lot from my patients. I'll have a patient who has a poor ovarian reserve and gives me one egg, and that one egg turns out to be a healthy embryo, and she has a healthy child, and she walks in and says, told you so. And, I'm not here to argue that. But on the other hand, when patients have had unfortunate situations in the past, they failed 4 or 5 cycles before. The last cycle in a reputable place only had one egg, and the egg either didn't fertilize or one egg that fertilized, but the embryo stopped growing in the laboratory. There's not a lot of things that we can do to enhance that particular patient's success.
Thank you for that, and your honesty as well. You mentioned
honesty is what you need.
Yeah. So just about your clinic, do you normally have overseas patients as well in normal times?
In normal times, 85% of my patients are international.
Really?
In fact, we have babies from 100 different countries worldwide, which I'm very proud of. And, I start with phone or Skype or WeChat or WhatsApp video chats, initially, and either they'll come here for all their care or they'll start with their care in a different country and come here. So prior to COVID and the banning of international travel, we had a very, very diverse patient population from all over the world. And that has been the way I've practiced for probably all 25 years in practice.
Yeah.
I told you about the woman who was stuck in an airplane on 9/11, so that's already 19 years ago.
Yeah.
We had a patient. I've had more than just one patient, but I'll tell you a quick story. There's a woman who was born and raised in New Caledonia. So New Caledonia is a French island outside of Australia, I believe under French rule. Pictures I saw were spectacularly beautiful. She was born with something called Rogatansky syndrome. So it's a normal genetic woman, very small vagina, no uterus formed. And so she learned from a young age, because she didn't have periods, that there was an anatomic issue that would prevent her from having a child on her own. At the time when I took care of her, which is more than 15 years ago, there was one flight from New Caledonia to the United States a week. She started her protocol in New Caledonia, came here. I got eggs from her, sperm from her husband, created embryos, and a surrogate carried for her, and she had her healthy genetic child. I've also had a male couple who have children with us also from New Caledonia, but it doesn't matter where people are from. It doesn't matter what they're interested in. One of my patients started a charity called the Just Like My Child Foundation in rural Uganda. I went there 2 times, once to lecture and help them set up a hospital, and then once to show my son what they were doing there, and our whole family's been involved with them. There were patients that we saw that walked like 3 days just to meet me, and when I returned, found out that they were able to get pregnant with some of the things that we had recommended for them. So it doesn't matter where people are from. These are challenges that everybody faces, and I think especially during this COVID time where we are reevaluating what are the really important things to us, to our life, to our family. Family is number one, and you close your inner circle, and you close it because government closed your ability to go out and have fun. So you're doing things at home or what have you. But this is a very, very good time for patients who have more time on their hands to learn about this, to understand about this, and many women who usually travel quite a bit or have very stressful, hectic times, maybe this is the time for them to freeze eggs. Maybe it's the time for them to freeze embryos. I know your country was the first to start having vaccinations. We are having vaccinations here. My wife was born in Morocco, grew up in Israel. Israel is the leader right now in terms of number of patient population that they were able to have vaccinated. I'm hoping that the United States will be able to have more and more people vaccinated, but there's a tremendous demand and the supply is very low. And obviously there's logistical things, because you can't just, because of the way in which the vaccines are stored. It's very difficult to be able to have it in any of the smaller facilities.
Absolutely.
Our American college, sorry, I'm just going to talk about the vaccine because everybody asked me about it.
Well, so. I know we've got so many questions. We can talk about that in a minute, but I just wanted to find out a little bit, or just to explain to people who have joined, that last night we announced this amazing global initiative from Fertility Help Hub, where we've partnered with 8 top fertility providers, and La Jolla, Dr Smotrich is one of them, and they're very, very kindly donating a cycle of IVF to an individual or couple who's been affected by COVID, who wants to restart their fertility journey and create their family. So thank you for that opportunity. And if anyone who's just joined didn't know about this and wants to check it out, you can find out more about La Jolla IVF on our website. The link is in the bio, and also about Dr Smotrich. And you just covered so many amazing topics. Did you want to touch on anything else before?
I'm sorry, just the COVID vaccine is something that I'm being constantly asked about. So the Moderna and Pfizer mRNA vaccines are available in the United States, and all our large OBGYN USA groups American Fertility Society, or American Society for Reproductive Medicine, American Society for OBGYNs, the maternal fetal medicine, and the urologist all recommend that patients that are interested in getting pregnant, patients that are pregnant, patients that are lactating, that they should get the vaccine and they feel that it's safe. So also for a urologic patient who is going to participate in this on the male side, it's safe as well. So I'm sorry, I because of the importance of that, I feel that that's something I needed to touch on.
And for people who may have had COVID, should they be scared that it may have affected their fertility?
So it's not 100% understood, but the level of this particular virus has varying effects on different people. So, and this is part of the reason why the spread of the disease has been so concerning. You have people who you can be talking to have absolutely no symptoms at all and are shedding virus, and you can have people that are, God forbid, losing their lives to the challenges that COVID present. In terms of on the male side, it is clear that it negatively impacts sperm, negatively impacts the ability for gentlemen to make sperm. Sperm counts are lower, and their frequent febrile episode that they have with this particular virus is quite detrimental to sperm. Now, after they've healed, and sperm that you evaluate today in an ejaculate is a 72-day marker leading up to from the time of the sperm is formed in the testes till it's ejaculated out. So it's not 100% clear if 6 months or a year down the road if things have healed well enough, because again, this is a new novel virus. In terms of women, the concern here is that they can cause embolic events and decrease blood flow to the ovaries. So I think it's something that we have to take very seriously. There's a debate about whether or not a woman or a person who has had COVID should subsequently be vaccinated. Right now in the United States, that is indeed recommended because there's about a 15 to 20% reinfection rate. You can have a new infection from a more aggressive mutation of this virus. And, just because you've been vaccinated or have had COVID doesn't give you, ability to run around without these masks and without washing hands and all the other precautions that are very important in preventing this virus.
Gosh, thank you. Thank you for that update. Well, thank you for answering everyone's questions. You have been everything you've said has been so insightful. I've learned a lot tonight, so thank you for your time.
Thank you so much. Good evening and good afternoon for those of us on the West Coast. And I look forward to the opportunity of working with you. And stay safe and focused on the positive. Being positive is the first thing that you got to embrace in this particular journey.
Absolutely. And for anyone who wants to have the opportunity of applying for this initiative that we're running, please head to the link in the bio on the Fertility Help Hub Instagram account or our website. You'll see it everywhere there. You can find out more. It's amazing. And I want to thank you so much for giving people this opportunity.
Thank you so much for the opportunity of speaking with you. Stay healthy and well. And
Bye,
hopefully in the future, I look forward to visiting your beautiful country.
And vice versa, coming back to America, finally.
All right.
Thank
Terrific.
you.
Cheers.
Have a good day.
Thank you
Bye,
so
everyone.
much. Bye-bye.
Thank you. Bye-bye.